Hello, everyone, and welcome. This is Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, the Director of Product Management with Persyst, and I'm here to introduce our speaker and topic for today's Persyst Grand Rounds. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. And each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. We welcome our speaker, Dr. Douglas R. Nordli, Jr., Professor of Pediatrics and co-director of the Comprehensive Epilepsy Center and Chief of Pediatric Neurology Section at the University of Chicago Medical Center. Dr. Nordli is going to speak today on tips for a busy pediatric epileptologist. And during this talk, you will learn how Persyst can help with the recognition of seizures in neonates and children, the analysis of spikes, and the detection of asymmetries. Dr. Nordli is a highly skilled neurologist with over 30 years experience who specializes in treating children with neurological conditions. Dr. Nordli focuses on pediatric epilepsy with a particular interest in early onset epilepsy, and he is passionate about understanding each child's unique condition so that he can provide targeted treatment for better results. Along with Dr. Nordli's clinical work, he is also actively researching methods to improve pediatric neurology care. Dr. Nordli is investigating techniques to predict and alter the course of epilepsy and examining how a novel method of classification of epilepsy can lead to better diagnosis and treatment. Dr. Nordli has been published in numerous peer-reviewed journals, such as the Journal of Pediatrics, Pediatric Neurology, Epilepsia, and Epilepsy and Behavior. Dr. Nordli is also involved in the education of medical students, residents, and fellows. He mentors fellows and has developed CME courses to help guide pediatric neurology residents and fellows. Dr. Nordli has also given multiple lectures both during grand rounds and as an invited lecturer nationally and abroad. And so with that, I bring you Dr. Doug Nordli.
Thank you very much, Marie, and thank you for this opportunity, everybody, to participate in Persyst Grand Rounds and share with you some tips for how a busy pediatric epileptologist deals with life. Before I begin, I just wanted to give a shout out to the clinical neurophysiology team at University of Chicago. Our pediatric EEG techs care for a diverse community, including a historically underserved portion of Chicago. And they do it with great care and compassion and grace. And so the any quality that you are admiring about the slides is directly related to their work. So I wanted to talk to you a bit about, our common plight. And it came up in the context of this when the pandemic started. I converted to a virtual presence for a lot of my clinical work. And Audrey Otomo, who's at University of Chicago as a nurse practitioner, and I started a virtual second opinion clinic. And the premise of the clinic was pretty straightforward, that we would accept patients that were having difficulty controlling their epilepsy, pediatric patients. And what we did was we, of course, did an H&P, and as best as you can do it over video. But we also acquired the EEG and the MRI data, the direct data. Our scheduler, Rick Cashman, has done a lot of work in organizing that and getting it transferred over. And more recently have incorporated, of course, next generation sequencing information. And the idea behind this is that what we found is that many times the reason that a diagnosis may have been incorrect or that things weren't going well did not relate to the intelligence or the fund of knowledge or of the physicians caring for the child. It many times related to a misinterpretation of the primary data. And so what I found is for us to be effective, to really help children, we needed to have this capability to review the primary data. And in some cases, taking the EEG and the MR information and doing source localization. And with that, we've had actually really good results. And it's been a very rewarding experience for us. Now, that's in the context of everything else that we do, right? You see in the top right portion that our world is just becoming inundated with continuous EEG information. It's growing at such a rapid pace. And then when we're dealing with our patients, we have a large volume of data. Sometimes it's just ictal EEG information shown down here in the lower left. Sometimes it's MR information, in this case, functional MRI data for visual activation. And sometimes it's stereo EEG implantation with the derived information from that and next generation sequencing over in here. So in the midst of our very busy days with all these other things going on, we somehow have to synthesize this information for the good of our patients. So in the course of time, I've developed some methods for how I approach things, and that's what I wanted to share with you today. Is how am I trying to deal with all of this information? And specifically, I wanted to focus on our method of categorization of epilepsy, the way that I day-to-day approach screening EEG data, including ictal detection and spike analysis, and the use of various other features, including asymmetry index. So a bit about how I approach epilepsy. This all started actually in the early around 2010, when a request from John Ebersol came out. He said, Doug, it's time to work on the book and update the chapter and help with the organization of a chapter on pediatric epilepsy. So as I thought about it, I was thinking what about if we viewed pediatric epilepsy primarily through the lens of an EEGer? What would that look like? And so my team and I in Chicago, and Christian Korf, who's now in Geneva, we all started putting down thoughts. And then as I looked at this, it occurred to me that you could categorize EEGs into one of 5 features, and that those categories would be very helpful as a means of organizing all of the pediatric epilepsy syndromes. So we published this probably little known article in 2015 in Neurology. And over the ensuing, since we first started thinking about this, it's been about a decade, we've had plenty of opportunity to work with this categorization system and to teach it to medical students and residents and fellows. So this is at the heart of it. Is as I was thinking about, think about EEG, think about the spikes that we see. And how we often say, in addition to the topography, let's think about the morphology of the spikes. And one of the characteristics that we often address is, are the spikes stereotyped or pleomorphic? And then as you think about stereotype, what does that really mean, stereotype, and what does it connote? It connotes a familial tendency, right? When you look at Metrakos and Metrakos data or Brain-Weiser, it was thought that these spikes are inherited in autosomal dominant with variable penetrance fashion. Maybe some exceptions to that and some qualifications, but it's basically held up. So if you think about, on one end of the spectrum of stereotype spikes, on the other end, we have pleomorphic spikes. And what are pleomorphic spikes associated with? A focal structural lesion. So when we were wrestling with this, I was on the ILEE, International League Against Epilepsy Classification Commission, for about 7 years. We had the hardest time. How do we develop a cogent list that makes sense, an organization of the epilepsies? And when we knew the elements, we knew that it had to incorporate genetics and structural information. But the thing that tripped us up was genetics. So instead of genetics, if you substitute familial, then what I would submit to you is that all of a sudden things start to become crystal clear. in how you can categorize the epilepsies. So by familial, I mean what you and I do every day, like when we're taking a family history. So some epilepsies are going to be, as we'll see, autosomal dominant inheritance. So, a big chunk of the pedigree is going to have expression of the epilepsy. Other epilepsies are about 30% have familial. So you'll start to see some family members and so forth. So if you just do that, if you substitute familial instead of genetic and then keep structural, then a very rational organization emerges. So how do we think about it? We think about it if you look at the left-hand side of this, as things at the top are very familial. And as you go down, there's less and less of a familial component. Whereas another way to think about it is as you move down, it increases the likelihood that there may be a structural abnormality on MRI. And then as I started to compartmentalize this and working with colleagues and abstracting EEGs, I realized there is not an infinite number of patterns that you see on EEG. There are really 5 principal patterns. So how do we organize them? Let's start with the background. The background is critically important. So the background is going to be normal in the first 3 and show slowing in the last 2. In the case of the 4th one, it's diffuse slowing. In the case of the 5th one, it's focal. In terms of spikes, they're none or infrequent in the first type, which is the familial. They tend to be stereotyped in the next 2 and pleomorphic in the last 2. Later on, it occurred to us that, there's a simple way to organize this. Put it in a pie chart. So let me see if this helps. So if you look at this in a pie chart, in the northern hemisphere here, we have backgrounds that are normal backgrounds. And when spikes are present in the northern hemisphere, they will tend to be stereotyped. Now, by converse, in the southern hemisphere, you have abnormal backgrounds, and the backgrounds will show slowing. And if they show slowing, you'll tend, and if you're in the southern hemisphere, in addition to the slowing, you'll tend to see pleomorphic spikes will be the characteristic of the spikes. Now, on the western side, the findings are diffuse or multifocal in distribution. And on the eastern side, they are focal in nature. And so it all clicks into place. The familial epilepsies are floating up here above all this because many times interictally, there are no epileptiform discharges. And sometimes the epileptiform discharges when present can be focal or generalized. So that's why they're floating up here as a kind of a little bit of a separate compartment. You see over here, number 2, this is genetic generalized epilepsies. What are their characteristics? Normal background, diffuse stereotype generalized spike waves. Number 3, the self-limited epilepsies, like a classic example would be Rolandic, now called SELECT. And what do you see? Normal background with focal stereotype spikes. Now, when you move on to category 4, you're getting diffuse slowing in the background and pleomorphic, multifocal, and diffusely distributed spikes. And finally, in the 5th category, you have focal slowing, sometimes with attenuation, and focal pleomorphic spikes. That's it. 5 categories explains all of pediatric epilepsy. So with this lens, it starts to make sense about how you can approach patients in a very orderly fashion. Now, the ILEE, you've all seen this, put out this very nice diagram of you move from seizure types to a thing called epilepsy types, which is a little cryptic to me. And then somehow you move from epilepsy types to syndromes, but the arrows don't really, you can see they don't line, the categories don't line up. What does this all mean? So let me modify this for you a little bit and substitute this in with one insertion. So we're going to start with the background of the child. And this is how I, honest to goodness, the folks at UC will tell you that I'm always insisting with the fellows and the residents, tell me the background and the chief complaint. I want to know, is it a normally developing child or a child with some challenges? And if so, what are they, or significant risk factors or family history? Just give that to me up front. And then next, we incorporate the seizure types. And so there, it's of course critical to do a detailed history, or nowadays, right? You say, well, you're asking the parents, like, what did the seizures look like? And the parents say, do you want to see them? And they show you in their cell phone, and you have beautiful video of the seizures. So then seizure semiology comes next. And then we add the EEG categories, which are critical, and the EEG categories logically follow into the epilepsy syndromes. So if you wanted to construct an equation, it's clinical background with seizure semiology, with EEG category, leads to epilepsy syndrome. It's very Bayesian in this process, right? The posterior probability depends upon the prior probability and some additional tests. In some cases, the test is a review of the seizure semiology. In other cases, it's a review of the EEG. So the thing that I found is that the EEG review, as well as the semiology, but I'm going to focus on the EEG review, is absolutely critical in getting the right epilepsy syndrome. And that's what's happened in the second opinion clinic a fair number of the time. So you've seen all the stuff on the right-hand side of this. What I'm going to add for you is the family history. As I noted earlier, it's going to be very strong with the familial epilepsies, autosomal dominant. It'll be about 30% of family of pedigrees will have positive, individuals with epilepsy. In the GGEs, in the self-limited epilepsy, we don't really know, or I don't know. And in conversations with Sam Berkovic, he's said that perhaps, if I'm not misquoting Dr. Berkovic, that's about 5% genetic contribution. So it's polygenic, but something else is going on here. And then this is in terms of the clinical susceptibility to seizures, of course, not the EEG pattern. And then rare, right? We have some instances where the family history is positive in patients with epilepsy and encephalopathy, like an example would be tuberous sclerosis complex. But many times you and I rely on the fact that it's not. And the way that we interpret the next generation sequencing results and determine a VUS from a pathogenic mutation is by figuring out, first and foremost, is it de novo? And then we do have genetic contributions, of course, to the focal epilepsies, like kids with dysplasia. And what we're learning now is that the vast majority of them have somatic mutations in the mTOR pathway. So you see what the problem was? You can't just say genetic as a simple category and get it and as a simple criteria and categorize your epilepsy. You have to be more specific about what type of genetics are you talking about. And that's where the term familial, I think, becomes very simple. All right, so that's the big brunt of what I wanted to share with you in terms of the categorization. I hope it's helpful. As Marie was saying, if this is new, if you haven't heard this description, you can look at it again. You can also reference that article. And I hope it is helpful, but honestly, day to day, I use this all the time. So once I've formed my categorization of how am I going to approach a child in a second opinion clinic, the next thing that I need to do is review their EEG data after I've reviewed their seizure semiology. And it's a lot, right? We get these discs and it's chock full of information. So how do I approach it? I use it and I put this mnemonic BATS. I don't know if that's helpful for you or not, but the first thing that I want to see is the background. Just like the background of the child is so important, the background of the EEG is the critical piece. And what I found, and probably you found, is that first wake sleep transition period, getting a good amount of sleep when the patient's kind of, calmer, settling down a little bit for bed, goes into N1 and then N2 is super valuable. So first look at background. And the next step is annotations. And this is why I wasn't just gratuitously referencing the EEG text, Celeste Sullivan, Chris Butler, and the whole team there, that saying like, their work is important. It's critically important. Having accurate annotations helps your work tremendously. So if you can look at those, the patient events, what the text saw that were really, important, then you can focus on the habitual seizure. Once you do that, then I examine the trends, and we'll talk about this in more detail. And I look to see what pattern on the trends matches that, so I can very quickly find other habitual seizures that can help me to kind of confirm or refute my hypothesis. And then finally, I look at the spike summary. I mean, of course, in kids, you get a lot of spikes, so I will have seen spikes in the course of all of this, but the spike summary is so helpful. And I want to share with you a tip that I've incorporated in terms of spike summary, particularly with ESI. Okay, so ictal patterns. Now, the good news is for focal seizures in kids, the ictal, they're very, very similar. Even not neonates, we'll talk about that in a sec. But once you get into infancy and beyond, focal seizures look very much like focal seizures in the rest of the lifespan. So let's take, for example, this 3-year-old girl who's having behavioral arrest episodes recognized as staring episodes. And you look at this EEG, I captured it here kind of in media res in the middle of the action. You can see that there's low voltage fast activity over here, and typical of an ictal discharge, it's changing in its topography, it's increasing in its spatial distribution as it slows in frequency and increases in amplitude. And so classic, right? Focal seizure is here. Here on the next slide, you'll see, to no surprise, it's not hard to detect. In this case, you can see the seizure probability. Persyst does a fantastic job of detecting all of these focal seizures, no trouble there. And you can see some other things. If you look down at the amplitude integrated EEG, you can see that the amplitude is higher on the right, right? If we go back to this, it's a right-sided seizure, so that makes sense. And it's more continuous, so there are fewer epochs of lower voltage activity embedded in this amplitude integrated EEG. So the red is right, the right trend is higher here. And if you look up just above in the asymmetry spectrogram, makes sense. There's more red again, indicating more right-sided activity over here across the frequency bands, more power across the frequency bands there. We go up here, we see the same thing on the FFT, the fast Fourier transform spectrogram. You see an increase in power in frequencies, particularly in the mid to high range here. And beautifully shown on the rhythmicity spectrogram is the difference in that. And you can see the increase in power in rhythmic frequency elements over here in the rhythmicity spectrogram. So super, right? Focal seizures, infants and above, are going to look very much like adult patterns, and Persyst does a beautiful job of detecting those. You don't believe it? Let me show you another example. So here you can see background asymmetry, of course, with higher amplitude, slower activity over here, perhaps more attenuation on the right. And then in the midst of that, you see the onset of an ictal discharge in the right hemisphere, maximal and the frontocentral regions. In the next slide, you see it developing and really kind of crescendoing right in front of your eyes. And as it does, it spreads to the contralateral hemisphere and it secondarily generalizes. Now, many infants, you can see here at 21 months, so 2 years and below, you usually don't get beautiful secondary generalization. You're not going to see the same degree of completely entrained spike wave discharges in the two hemispheres. And if you study this, you see that, oh, actually, the ictal pattern is not identical on the two hemispheres. And indeed, when it terminates, it's not perfectly symmetric either. So we wrote this controversial article some years ago saying that GTCs, true primary GTCs, are extremely rare in infancy in general and virtually never seen below 1 year of age. So just as a point. All right, so we look at the panel here. We've identified it. It's no difficulty. Persyst shows the seizure probability is very high. And you go through the same trend analysis and you can see not only, the activity that has started on the right, but evidence here of bilateral involvement, just as we saw in the EEG. Note also, you probably observed, I didn't comment, that there's an abruptly attenuated termination pattern here, or PGES, that's occurring. And you can actually see that both on the dip in the fast Fourier transform and also in the amplitude integrated EEG, that the bottom just drops out. So a lot of the features are there, and just like you would analyze in an older child or an adult, they're present even in infancy. So that's really good news. And I'll show you, here's an EEG of a 22-month-old who's had complex febrile seizures. Background is asymmetric, again, giving you a little bit of clue as to what is about to happen. And then you see this development of low voltage fast activity over here in the right frontal region. It is increasing in its amplitude as it changes in its frequency, as is typical. You'll see the poor man's polygraphic channel here in the EKG showing the accompanying, muscular artifact that's happening. And very similar to our other case, you see the result. And once again, I'm not going to belabor this point, just hope to prove to you that focal seizures are pretty easily dealt with in trend analysis beyond the neonatal period. Just walking you through the various components. One thing that I did want to show you is, if you look at this, you can see a difference in the rhythmicity spectrogram early in this seizure. And where is it? It's at FP2 to F4 and FP2 to F8. So it's kind of cool. Play around, if you haven't already, with the various panels that Persyst has to offer, kind of depending upon the circumstance and what you're interested in. But there's a lot of information that you can derive pretty quickly from the various panels. Now, in addition to that, you can use trends in the same way you would in terms of monitoring ictal events. And here's a recent patient we have, was an 11-year-old girl at UC who has NF1, and she had this prolonged period. She was having episodes of behavioral rest, but she came in with prolonged unresponsiveness. We had this EEG, which was startling to us. And here's another page showing you this. And in brief, she was in non-convulsive status. And what you can see here is a dramatic change in the seizure probability and the trends accompanying the administration of an anti-seizure medication here. And following that, the EEG remains abnormal, but it's focal, and that previous diffusely distributed epileptiform activity is no longer present. Okay, all well and good, but before you get too comfortable, let me introduce some more complex ictal patterns. So one example is neonatal seizures, and you can think of it in a variety of different ways. But the thing that stands out to us, right, in a neonatal study is that you don't have any sustained rhythmicity in the normal newborn recording. So that's one feature. Two, that you get an increase in the continuity, particularly of higher amplitude activity, which is going to become significant with the trends. And three, you see, because of this rhythmic activity, a change in the frequency domain that accompanies these. So here's an example. Let me show you a page of a newborn. And now you start to see, perhaps in this page, this rhythmic discharge, right? Quite different from what we would see in an older child or adult. Continues like this for quite some time. In this case, it actually changes a bit, but sometimes it will not. It will remain monotonous delta or just persistent rhythmic spikes. And this has more of an evolution, as you can see here, and getting even more dramatic. What's nice about this is that you can detect this pretty easily with trends. I like the amplitude integrated EEG, so I'll start at the bottom. We've just separated these out into neonatal posterior, right posterior, left posterior, vertex over here, right anterior and left anterior. And people have referred to this as the curtain raising sign. Our colleague, Dr. Julia Henry, introduced that to our team. And you can see that this elevation is characteristic of neonatal seizures. What's nice about this one, it's separated, it's pretty clean. And you can see that, oh yeah, it was clearly right-sided, but it extended to the vertex in this patient. But then later on, you can see, oh, it goes to the left. And you can appreciate the same thing on the spectrogram. So, oh, by the way, why did this happen? It happened because there was an increase in amplitude and it was sustained. So there were fewer epochs where in that time period, there was a lower component of amplitude activity in that epoch. So very little low amplitude activity in the epoch and much higher amplitude, which is why the lower portion of the line goes up. And On the rhythmicity spectrogram, you see it beautifully, right? It shows up really nicely in this case. And same on the FFT. It has that flame sign that we associate with seizures. Here's another example. You can see that flame sign even in this monotonous kind of this simplified neonatal seizure. But you can see this flame sign on the FFT. You see it beautifully represented on the rhythmicity spectrogram. And once again, the very dramatic changes on the amplitude integrated EEG. Here's another example, just walking you through, and you can see as it develops, you can see the concomitant changes in the trends in the middle of the seizure, towards the end of the seizure, and then afterwards. So it's really nice. You can use the same thing. In this case, we can drill down on the rhythmicity spectrogram and get more detailed information and seeing that, yep, it gives a nice way of showing us that this is right hemisphere. What I want to show you is something else that in examining trends can sometimes be useful, is that there's a relatively new versus baseline feature. So if you look at that and look at the fast Fourier transform, isn't that really cool here? How it shows very nicely in the versus baseline on the FFT. It stands out. Here's the kind of raw concomitant, if you will, FFT, and look at how beautifully demarcated that is. So, you might want to look at versus baseline FFT spectrogram sometimes if you're having difficulty correlating the seizures on the FFT. It'll still show up, of course, on the amplitude integrated EEG as you see it here. But that's just another tip of what may be useful for neonatal seizures. So this makes sense, right? Rhythmicity is the rhythmicity spectrogram. The amplitude and continuity is reflected in the amplitude integrated EEG, and the frequency, of course, is seen in the frequency domain is seen in the FFT, and that versus baseline is another feature that can be very helpful for neonatal detection. So once you're familiar with it, not too hard to find the vast majority of seizures and very efficiently. The details of the seizures matter, and this is Roberta Cilio has published, as well as others, that there are differences in neonatal seizures and differences in the trending. You can see here that there is a dramatic diminution or a kind of like abrupt attenuation after the seizure. And in this article, they're suggesting that this could be an important indicator that you're dealing with the KCNQ2. And thank you for the question. I'm going to have time. I won't ignore it. We'll have time and get to the questions, which are really helpful towards the end of the talk. All right, now tricky things. So here's a 6-month-old who has a sudden onset of paroxysmal events, and you take a look at this page, and in an instant, we're in trouble. We are in category 4. So category 4, remember, is a slowed background that lacks the normal organization. There are multifocal pleomorphic spikes that are present. And importantly, in this epoch, you see an epoch of discontinuity. So when you see that, by the way, you are most likely dealing with what you could consider an epileptic encephalopathy, meaning within the spectrum of Odahara or EME, now early onset epileptic encephalopathies, to West syndrome, to something we'll touch on called LAEE, or even Lennox-Gastaut. How are you going to find these? This, I'm not going to lie to you, is challenging. So you really have to hope that you have good annotations from the technologist and a parent that's nearby to catch everything. Otherwise, you're going to be stuck doing some brute force review if you wanted to characterize every single event. One tip is to use polygraphic activities. So applying an EMG, a surface EMG, we usually select the right side, like approximately 2 centimeters apart. And the paraspinal muscles are very helpful, particularly for this type of seizure. And you can display that concomitant with the EEG, and it's tremendously helpful. Now, so you look at this FFT and you're like, oh my goodness, Doug, where is it? Like, I'm not seeing this. This is, as you can see, is an electrodecrement. It's going to be the start of a cluster of spasms. And at this, time frame, looking at it, over the course, if you look at it over 1 or 2 hours, like we're doing 1 hour here, it's going to be very hard to see. But there's a very important clue that's present here, and one tip that I'm going to give you. So you saw what the background looks like normally in this child, in this infant. Notice what's happened to the background. That when many babies, but not all, are having a cluster of infantile spasms, their background has pseudonormalization. So an important clue to this is given to you right here. When you see that the spike density has suddenly dramatically changed for a prolonged epoch, pause and look very carefully at that section of the EEG. It's highly likely one of two things has happened. Something's alerted the baby and they've had a change of state, but much more frequently, they're experiencing a cluster of spasms. So you can see sometimes minute changes in the amplitude integrated EEG, but not when you're at this resolution. If you focus down, you'll see the attenuation on the amplitude integrated EEG. But look what I had to do. I had to change it to instead of hours, it's now we're in minutes. So it's helpful, but not as helpful, I think, as looking for the spike density. And of course, looking when you if you can resolve it, and sometimes you can't because hypsarrhythmia, the sleep architecture is so disrupted, but if you could resolve it, look to where you're seeing, of course, the state transition, and that's another time to slow down your review and pay attention. Well, another seizure type that is in this spectrum of 4B, or epileptic encephalopathies, is associated with a syndrome we call late infantile epileptic encephalopathy, and it's a myoclonic tonic seizure. You see that the EEG is abnormal, but notice not quite as high amplitude as full-blown hypsarrhythmia. This usually starts beyond 1 year of age, and the patients have this seizure type, either spasm or myoclonic tonic seizure type. It clusters, but not as regularly as you see with infantile spasms, where the spasms are almost clock-like in their periodicity. Not so with myoclonic tonic or spasm tonic seizures. They cluster, but there's an erratic time period in between each individual seizure. You can see this reverse check mark appearance on amplitude integrated EEG, but again, we had to really kind of like shrink down the trend to like minutes. So the same thing, look for a period where the spike probability dramatically decreases, and that's going to be a clue that you may be seeing a cluster of these types of seizures. Alrighty, and the third seizure type that's challenging, you see here, was not in this case detected by Persyst, but sometimes it is a tonic seizure, and particularly a brief tonic seizure. But look, here's your clue on the rhythmicity spectrogram. You see a burst of activity, and look for it associated with a dip in the fast Fourier transform. Why? Because the frequency elements dropped out, but you got a buzz of higher frequency rhythmicity that shows up very nicely in the rhythmicity spectrogram. Okay. So those are a couple of tips for IGDL. You can rely on transfer a lot. There are a couple of seizure types that you cannot. So if your history and your seizure semiology is suggesting that, you've got to go by annotations or a couple of these tricks. All right. I want to move on to spike analysis and just share with you something that I've been incorporating lately that's really helped us. Weekly, I get to interact with this guy, Wim van Dragelen. He's a signal processing expert that's written this book on signal processing. And we review all of our EEG source localizations together, which has been really a wonderful educational experience for me. So let's get back to this notion of the pleomorphic spikes. If you simplify it down, many times what we're trying to do is pick out spikes that look super similar to one another. And we're very rigorous about this. So we hand select the spikes, and that is an excellent way to proceed. Another way to think about it is to say, well, what if the spikes vary only a little bit? Can you rely on detection of spikes? Will it give us a reasonable, answer to the problem of source localization? Because that hand picking of spikes can be very, can take let's, quite a bit of time, and we don't have a lot of time, right? We're busy clinicians. So what if you average these? Would you get a result that's reasonable? The idea behind averaging is that if you look at the standard deviation, you can see it's going to be inversely proportional to the square root of the number of observations. And recently, there was a publication from the Geneva group showing that a semi-automated in-rectal EEG source localization paradigm works very well. So we've been doing this ourselves. Here's one example of how you do it. You take an EEG that's showing you epileptiform discharges. You then analyze the spike report. You select the group that you're most interested in. And then you could go through that group and, of course, handpick. You could also say, well, let me take the entire group. And then you can export that to a V-plot and render it here. And here you can see it showing all 744 spikes, and you can display it over time. If you convert it to the AMP recorded montage over here, then you can easily export this as a text file. And then we use Curry. You can import it into Curry. You just have to make a little bit of, turn off the first two channels because they're going to be an arbitrary annotation for the number and then also the time, of course. But then you can input it into your EEG source localization. Here is a different example, not that same patient, but another patient that has Rolandic spikes. And I just did this just to show you. This was a case that had many 1,378 spikes. And the reason I wanted to point it out is look at the ellipsoid. So that's the ellipsoid, right? Which you can barely resolve. Look at the map. This is the actual map. That's the map that the computer is going to utilize for the source localization. Pretty darn good fit. And you can see the result of that. If you went even more, and this is just a blow up just to show you how tight the ellipsoid is. If you use 8,174 spikes, now granted, I told you they're Rolandic spikes, so they're stereotype. But look at this. You can't even make out the ellipsoid in this particular example. And here's the actual recording, and here's the model that is going to be used for source localization. So the numbers matter. If you want to, say, reduce your standard error by 20-fold, you need to increase your observations by about 400-fold. And so this method has really helped me. I feel like, okay, I'm taking it all with a grain of salt. I'm not going to bet the farm on just one source of data, but it gives me the opportunity to not only, localize to a lobe, but I think even sublobar precision. Now, the problem is, when you think about it and think about what's generating this, the vector is very accurate, but you can't always rely on the depth of the spike focus. So here's an example of a patient that we recently had at University of Chicago. And this patient actually had fixation off sensitivity, and that's another story. But you can see this occipital spike that was from a spike average, and forgetting, but it was like about 100 or so average spikes that you can see here, or it might have been several hundred, and pretty good ellipsoid. You can see it's the vector of this is pointing more towards a deeper, in line with like somewhere on the axis of a deep source to the surface over in here. And if you look then at the ictus, though, it was interesting. There was a DC shift in the ictus, so you could look at the DC shift. And the DC shift points to something that's much more, it's flipping of the sides. This is still the right side, of course. It points to a deeper source. And if you look at the current source density, then you can see, yes, this is now the initial rhythmic activity in the beta frequency range associated with this seizure. So in retrospect, what do you believe? Is this quote unquote ictal analysis, the early features, the accurate thing? Was it the interictal source localization, or were they congruent because it was pointing in this direction and telling you, how the spike is traveling, if you will, but not necessarily the depth? And anyway, we got that from just quickly spike averaging. So I think it can help you orient you to the lobe and even sublobar location, but be cautious about interpreting the depth of a dipole calculation. All right. Last thing that I wanted to just touch base on briefly before we have a time period for your questions is how we use trends related to symmetry. So here we had another patient not too long ago, an 11-year-old girl who had a seizure and a headache. And you can see in this page, and perhaps it's evident to many people that, oh, there seems to be a discrepancy in the amount of faster frequency elements on the right compared to the left. But on this page, might be hard to appreciate. But you go to the trends on this page and look at how beautiful it is. It really is clearly showing a differentiation on the fast Fourier transform, the relative spectrogram. You can see that there's an increase in faster frequency elements on the right side, relative decrease on the left, which correlates very well. And, looks exactly like that page of EEG. And to no surprise, you can see, oh my goodness, the patient has a subdural that's present on the left. And so that makes sense. What was attenuating the faster frequency elements on the left side? Here's another example of a boy who tripped over a gate and became unresponsive. And you can see here really marked asymmetry in his EEG, right? Maybe you wouldn't see that, or maybe you would on this slide, depends on how much you were focusing on the posterior rhythm over in here. But super clear on the trends, right? Now, you have to be cautious because, and this correlated, what happened, we believe, with him is that he had an arachnoid cyst that ruptured, and that's what caused the abrupt change in his mentation and also his EEG pattern. But you need to be cautious in interpreting the trends. So here, let's take a look at this. And you'd say, okay, let me take that back. It's not interpreting the trends, it's interpreting the EEG data in total. So here we see higher amplitude activity on the left, and it looks like better high frequency activity is evident over here on the left, and relative diminution. So our old EEGers rule is generally go with the side of attenuation. And the trend analysis is showing us the same thing, saying like, wow, a lot more voltage is evident over here on the left as compared to the right. But sadly, this was due to a gunshot wound, which sadly, again, we see way too frequently nowadays. And of course, this caused a massive breach effect, which was resulting in that asymmetry. So the side of attenuation is not always the side of pathology. But sorry if I went a little fast, but there was a lot that I wanted to share with you. And if I can summarize this, so what I wanted to say is that we need quantitative tools to help us to keep up with the increasing workload. We need to incorporate some schema, some categorization, some method that we use time and again to help us get through all of this data and making sure we're not missing things. So I pointed out this, acronym of BATS, background, annotation, trends, and spike detection that I use. I also went through the EEG categorization and how we use the EEG as one of the fundamentals for deriving the EEG syndromes. To show you that, we can render this. We recently published this as a modification. Douglas, my son, Mohammed, Dr. P, and others, we put together, Mohammed, this beautiful rendition of the figure here. And you can if you take my word for it, you can put all of the epilepsy syndromes in this kind of a fashion so that you can incorporate that information. Next, trends are the most efficient way to spot seizures. Think of them, it may not be intuitive to us, and you have to think about what we're seeing. We have to think about things in the frequency domain, the continuity and the amplitude for the amplitude integrated EEG, and the rhythmicity with the rhythmicity spectrogram. In terms of detection, you'll be able to detect the vast majority of focal seizures. The ones that can be tricky are spasms, myoclonic, tonic, and tonic, but there are clues. And particularly for the clusters, look for epochs where the time where the the spike density decreases. And finally, a semi-automatic method of penultimate thing, a semi-automatic method of spike averaging can work very well. And lastly, the examining the trends can be very helpful. So, I mean, I would vote still for a careful visual analysis. If you see something and you suspect something, check it out on the trends and see if it helps to verify your hypotheses. Okay, I am going to pause here and thank you for your attention up to now, and I'll turn over to questions.
Great. Thank you so much, Dr. Nordli. That was a very interesting talk. We do have some questions here. I know that you already saw the first one that came in earlier. That question is, I noticed that many of your trends were adjusted to 1 to 10 hertz rather than 1 to 25 hertz for rhythmicity or 1 to 20 hertz for FFT. Do you commonly do that for neonates? And at what age do you use the larger frequency range?
Yes, thank you. It's an excellent question and an astute observation. And yes, we commonly do because of the frequency elements that you tend to see in neonates. And as soon as we get out of that period, and start to get into infancy, 3 months and beyond, I would convert to incorporating the faster frequencies as well. I actively discourage people from ordering EEGs between 6 weeks and 3 months because two things. It tends to be a time frame where you don't see a lot of ictal activity, and two, it's very hard to glean much useful information from that. It's just a blur of diffusely distributed delta and theta activity. So by 3 months, when we really seizures start to pick up again and we see more declarative information, I think you should convert to using higher frequency elements.
That's interesting. Okay, and the next question is one about education. Do you think that all these quantitative tools should be taught to young epileptologists?
Yes, merci, Laurent. Absolutely. We're doing that. We're incorporating that at UC. I think it's going to be the same thing. You know how you and I would look at an EEG and we would say, it's like you almost don't even think about it. You just see and you intuitively know what's going on. It's not going to be that way with trends unless we introduce them to people early on in training. So I 100% agree.
So what's the strategy at your institution then when a young epileptologist, are you teaching fellows? What does that look like at your center?
We're starting with the residents. Child neurologists have spent a lot of their time dealing with epilepsy and seizures. So we start off, we have a boot camp when they first get introduced to pediatric neurology. So 1 week, well, it's spread out now over several weeks, but it's kind of intensive course introducing them to EEG. They're at our shop and many others, they're, not encouraged, but really, the expectation is that they will review the EEG on their patients. And so as they're doing that and learning about the patterns, then we start incorporating the trend analysis as the next step.
Great, thank you for that. There is a question about what is the probable percentage of ictal activity on quantitative EEG that is not recognized?
Ooh, that is an excellent question. I honestly don't know the answer to that in general. I think it will depend a lot upon the specific, seizure type that we're interested in. I think it'll be low for focal seizures and probably, I don't know if Mark Scheuer's on the line, he can give you the exact amounts. For things like spasms and myoclonic tonic seizures and very brief tonic seizures, I'd say it's going to be more challenging. That's I used to like to read EEGs totally blinded, and now I don't think that's because I was worried I was going to get biased, and now I don't do it that way. I like to hear what the problem is, and I like to formulate in my mind what I'm looking for. I still don't know for sure, and I can confirm or refute that hypothesis, but I feel like I need to go into the EEG at least having some concept of what will make my review most efficient.
Yeah, that last example was pretty profound. Okay, so then another question. Do you think that EEG trends could help in precision medicine? And for example, KNCQ2, KCNQ3, etc., for unique ictal patterns?
Yes, I do. I do think this is going to help us in precision medicine. Um, I think in two ways. I think one way is that we have, particularly in this topic of epileptic encephalopathies or
Mhm.
epileptogenic encephalopathies, and mostly due to children with monogenic mutations, we don't have any way right now to accurately follow their cognition.
Mm.
We know how to track seizures, parents can count them, we can do that. But we need some method to
Mm.
accurately assay the cognitive abilities of patients because we have two goals, right? One is stop the seizures, two is return as much as possible them to normal cognition. So we can't wait for the next Bailey or the next IQ test. We need something that we can assay, and I completely agree with you. I think quantitative analysis is the way to go
Mm.
on that. Two, I think yes, that we're going to figure out. This is going to be a very exciting time period, but I think we in the epilepsy community are going to figure out how to derive information about the mechanism of pathogenesis in these monogenic epilepsies, and they're going to have associated EEG patterns, and maybe some of that is going to require quantitative analysis as well. So I completely agree with that. Where that question is leading. That I think
Mm.
yes, quantitative EEG is going to become even more valuable in the as we move on and deal with children with hard to treat seizures.
Nice. Nice. Thank you for that answer. Another question on education. Would you consider doing or would you see a value for classes for registered EEG technologists for hands-on, where they would be able to hone their trend reading abilities?
I think that is an excellent idea. I look at it like, I mean, we're blessed with fantastic techs at USC, for example, but they get called away, right?
Yeah.
They have to
Yeah.
go hook up somebody. They need to come back. So you need belts and suspenders. You can't rely on just somebody always being vigilant to a screen. We need
Mhm.
some other way to make sure that epochs of interest are detected. And so I think trends are really important. And I think, training EEG techs on how to optimally interpret trends would be very valuable.
Fantastic. And then my next follow-up question to that is similar to the previous one. What does that look like at your institution? How do you work with the technologists, or do you, to help them interpret trends?
We do. They come to we have a weekly EEG conference
Mhm.
that where we discuss interesting EEGs and we incorporate a variety of things. We try to make it, interesting to a variety of learners, including trend analysis. And so our texts come to that.
Mhm.
Um, I, the texts, to be totally candid, have been asking me, how can we learn more about trends? And so I think that's something that question and this other question are reminding, like, okay, what else are you doing with your time, Doug Nordli? No, I think that's really important. And yes, we have to carve out more time. Well, fortunately, our residents learn a lot. Our epilepsy fellows they learn a lot about trends. So we have a lot of resources. So the more that we pull together, it won't be on, and just the epileptologist to do this training.
Right, right. Yeah. Okay, thank you. And Dr. Bhatia asks, do you use quantitative EEG to calculate spike wave index in ESIS?
Yes, you can. Um, and there are research protocols that are underway that do that. So yes, that can absolutely be done.
Great, thank you. And then there's a comment from Dr. Mark Scheuer here, I think in response to your comment earlier. He says that there is a very high seizure recognition rate for trends, but no one has a global number. And as you noted, Dr. Nordley, this will depend on the seizure type, specifics of the group being assessed. So for example, lower for spasms, tonic seizures, but those are relatively uncommon. Yeah,
Yes, yeah,
okay,
yeah, very helpful.
great. I really want to thank you for your time. And this really has been a fantastic talk. Before you go, I actually wanted to ask you one last thing. You have over 30 years experience. I think it's actually closer to 40 years experience now in the field. And so you've seen a lot and you've seen a lot of changes. And I wonder if you could give us your thoughts on, where you see the field going from now. What the most important advances in technology are yet needed. You mentioned one, the need to assay cognitive abilities in these patients, which I think makes a lot of sense. But, is there anything else other than that in terms of the directions that you think the field needs to head? And then a follow-up question to that would be, what have you been over the last 40 years the most inspired by in terms of these kinds of changes that you've seen taking place, and what gives you hope for future generations? For example, knowing that your son is coming up as another pediatric epileptologist. So what gives you hope for the future?
I'm extremely hopeful, Marie, for the future. Like it honestly, this has been like I'd say the last 5, 10 years, the most exciting epoch that I've seen in the last 40 years. And I would put two of the things that you're alluding to together. One is all this information that we're getting from next generation sequencing, and that we'll get from, we get right now from whole exome, and then we'll get from genome. And then as we understand that, that's a key to so many causes of intractable epilepsy. What we need now, and to answer your other question, is we need to understand the genotype phenotype correlation. So we need to know specifically what has gone wrong. So, with any particular gene mutation information that we get, we don't intuitively know, and many times it's not published, whether it's gain of function, loss of function, what pathways is it disrupting, how is it actually causing epilepsy. I think the clue is in the EEG. I think the
Mm.
EEG has always been our most indispensable tool. And so I think getting a better understanding of the EEG manifestations of these, mutations will point us in the direction, so that, take for example, SCN2A, right? If we could figure out a pattern there that are like, oh, the EEG tends to show X when you have a gain of function, then we would know, okay, let's rapidly
Mm.
give a sodium channel blocker. So we could quickly go to a more precise treatment, rather than have someone take the mutation out, express it in an oocyte, patch clamp it, and so forth. If we could figure out those connections, and I don't think there's going to be, you know, hundreds of different patterns. I think it's going to come down to discrete, manageable number of ways that the EEG changes in response to these mutations. That I think is the most exciting area, and I'm extremely hopeful that we're going to markedly decrease the prevalence of refractory epilepsy in kids.
Wonderful. Thank you so much for that. That's a great perspective. Very much appreciated. So, there was one last question, and I know we are over the hour, so I'll give us this one last question and then we'll wrap it up. Um, so for ESIS SWI spike wave index calculation, do you see high, medium, or low specificity criteria?
I guess it would depend on what the question is that you're looking at in the clinical context. So maybe this is something that we can take offline.
Mm,
There's another component to this. I think even more clinically useful as to when do you see these patterns electrographically, and what's their clinical significance.
mm-hmm.
So, um, like I think you mentioned earlier, Marie, that if the questioner would want to share email, we can go back and forth on this. It's not going to be it's going to take a little bit more of an extended response to this
Yes,
question. Yeah.
that's a great actually lead up to the wrap up. I did want to ask you if there's a way that folks can follow you or get in touch with you, or alternatively, of course, we have the contact list, and so I can share the email of the person who asked the question, and you can proactively reach out. But is there a way that folks can keep up with your work?
Oh, yeah, absolutely. I mean, I'm not, despite like interest in quantitative EEG and source localization, I wouldn't say I'm the most socially accessible person,
Yeah.
or computer literate, like as you observed earlier. Um, but but I think if the participants are agreeable, people that have questions, you can give me their email. I promise I will write
Great.
out to them and we can
Okay.
connect through email.
Okay. We'll do it that way. Thank you so much.
You're
Um,
welcome.
okay. So unless you have any other comments, I think we've accomplished what we came here to do today. So again, I want to thank you so much for your time. This has been a wonderful talk and we're all very appreciative. Thank you very
Pleasure.
much. All right.
Thank
Thanks.
you.
Thanks everyone. Until next time. Bye-bye.
I know.